Did medieval women live in a constant state of fear about their bodies? Were they always at the mercy of poorly understood diseases and rough treatments in the period spanning roughly 500 to 1500 CE? Number 1. Medieval women were only treated by men and had no agency in their medical decisions. The idea that medieval women existed solely under the medical gaze and directive of male physicians, without any say in their own health journeys, often pops up in stories about the distant past. It paints a picture of women as voiceless patients, their bodies and well-being entirely dictated by male authorities or by circumstances beyond their control. This picture is not entirely accurate, leaving out much of the vibrant and complex reality of healthcare in the Middle Ages. Women, in truth, navigated a diverse landscape of healing, often choosing who would care for them and how. Their medical choices were sometimes influenced by their social standing, their financial situation, and the availability of different types of healers, but choices were made. In the bustling towns and quiet villages of medieval Europe, the medical marketplace was a busy place, far more varied than just a male physician and a pointed hat. People had options. Women frequently sought the care of other women, especially for conditions related to childbirth, menstruation, and general female health. Midwives, for instance, were the cornerstone of reproductive care, and their presence was not a matter of choice for women, but an absolute necessity. A woman expecting a child would almost certainly call upon a midwife, often one recommended by her female relatives or neighbors, a woman known for her skill and experience. These midwives were respected figures in their communities, often holding a great deal of practical knowledge passed down through generations. They assisted births, but their role extended far beyond that. They advised on pregnancy, offered remedies for common ailments, and provided emotional support. Their expertise was invaluable, and women actively chose the midwife they trusted most to guide them through one of life's most perilous events. This was not a passive acceptance of male authority. It was an active selection within a female-dominated sphere of care. Beyond midwives, a multitude of female healers populated the medieval world. Many women were skilled herbalists, knowing the properties of various plants and how to prepare them for medicinal use. They collected herbs from fields and forests, cultivated medicinal gardens, and concocted salves, poultices, and tinctures for a wide range of conditions. A woman suffering from a fever, a cough, or an aching joint might turn to an older woman in her village known for her herbal remedies. These transactions were often based on reputation and personal trust, allowing women to seek out the healer they felt would offer the most effective and sympathetic treatment. These were not formal medical professionals in the university-trained sense, but their knowledge was highly valued, and their services actively sought by women who wanted relief and healing. Or furthermore, women in wealthier households, or those in positions of authority, sometimes had access to even more specialized care. While university-trained physicians were predominantly men, some women did engage with them, especially for serious or chronic conditions. However, even in these cases, women often had significant input. A noblewoman might discuss her symptoms with her husband or household steward, but the ultimate decision to summon a physician, and indeed to follow his advice, would often rest on her own discretion and comfort. Her household might employ a range of healers, from formally trained to the experienced lay practitioner, and she would have the capacity to choose among them. Records show instances where women, particularly widows or those managing large estates, directly commissioned treatments, purchased specific medicines, or sent for particular healers known for their expertise. This demonstrates a clear exercise of agency in controlling their own healthcare. The concept of agency extended to the very personal decision-making about family planning and reproductive health, even if the tools available were often imperfect. While the church frowned upon contraception, evidence from medical texts and folklore suggests that women possessed and transmitted knowledge about preventing conception or inducing abortion. Women would share recipes for herbal concoctions or discuss practices believed to influence fertility. Whether these methods were effective or not, the very act of seeking and employing them points to a conscious effort by women to exert control over their reproductive lives. This was not a realm where men solely dictated outcomes. It was a deeply personal sphere, where women made difficult, often secretive, choices based on the knowledge and beliefs available to them. Even within formal institutions, women were not always just passive patients. Convents and monastic hospitals, many of which were run by nuns, provided significant healthcare services. Women seeking care in these settings would interact with female caregivers, nuns who had dedicated their lives to tending the sick. These nuns were often quite knowledgeable about basic medical practices, herbal remedies, and nursing care. A woman choosing to seek care in such an institution was making an active choice about her healthcare environment and the gender of her caregivers. The empathetic care offered by these religious women likely made them a preferred choice for many female patients who might feel more comfortable discussing their ailments with other women. The financial aspect also played a part in medical choices. Formal male physicians, especially those trained in universities, could be expensive. Many women, particularly those from lower economic strata, would naturally turn to more affordable or even free options: the village herbalist, the experienced neighbor, or the remedies prepared at home. This was not a lack of agency, but a pragmatic decision based on available resources and established community networks. A woman might choose to rely on home remedies and the advice of her female kin rather than incur the significant cost of a physician, a choice that reflected her autonomy within her economic constraints. Furthermore, women often played a crucial role in the healthcare of their families and households. As the primary caregivers within the domestic sphere, they were responsible for nursing the sick, preparing remedies, and making decisions about when to seek outside help. A mother caring for a sick child or a wife tending to an ailing husband would make countless small medical decisions daily, from what foods to offer to what herbs to administer. While not always directly about their own personal health, this constant engagement with healthcare gave women a deep, practical understanding of illness and recovery, empowering them in their own medical encounters. Their domestic knowledge was extensive, making them active participants, not merely passive recipients, in the health and well-being of their communities. The prevalence of female practitioners, from the indispensable midwife to the discreet herbalist, clearly shows that women had alternatives to male physicians and often preferred them for certain ailments or for reasons of comfort and familiarity. The decision to call upon a specific midwife, to consult a known female healer, or to rely on home remedies passed down through generations all highlight the active choices women made regarding their own health care. They were not simply told what to do. They sought out, selected, and often paid for the care they deemed most appropriate and effective for their unique needs. This network of female support and expertise offered women a significant degree of agency in a world often depicted as entirely controlled by men. The medical landscape was far more nuanced, allowing women to navigate their health journeys with a surprising amount of independence and decision-making power, a facet often overlooked when examining the past. Number 2, medieval women were ignorant about their bodies and reproduction. A common myth suggests that medieval women possessed little to no understanding of their own anatomy, menstrual cycles, or the mechanics of reproduction. This idea paints them as living in a fog of ignorance about the very bodies they inhabited, waiting for male scholars or physicians to explain the mysteries of life. This perspective greatly underestimates the wealth of practical knowledge, observations, and theories that medieval women and the broader society they lived in possessed about the female body and its functions. While their understanding was certainly different from modern scientific views, it was far from ignorant and was deeply integrated into their daily lives, beliefs, and practices. Medieval understanding of the body was largely based on the theory of humors, a system inherited from ancient Greek medicine. This theory proposed that the body was composed of 4 fundamental fluids: blood, phlegm, yellow bile, and black bile, and that health depended on their balance. While this framework applied to everyone, women's bodies were often seen as having a distinct humoral makeup, specifically being colder and wetter than men's. This idea influenced how people understood female anatomy and physiology. For instance, menstruation was often understood as a necessary way for women to purge excess humors from their bodies, a vital cleansing process that maintained their balance. Far from being ignorant about this, women understood menstruation as a fundamental aspect of their physiology, something connected to their health and fertility. They observed their cycles, often relying on moon cycles or agricultural rhythms to track them, and understood that the cessation of periods was a primary sign of pregnancy. This observational knowledge, passed down through generations, was a cornerstone of their understanding of reproduction. Information about female health and reproduction was not confined to academic texts read only by university-trained men. It was circulated through a variety of channels, most notably through oral tradition among women themselves. Mothers taught daughters, older women advised younger ones, and female community networks shared practical wisdom about managing menstrual discomfort, navigating pregnancy, and ensuring safe childbirth. This informal education was incredibly rich and detailed. Women discussed symptoms of pregnancy, methods to ease labor pains, and ways to care for newborns. They learned about herbal remedies to stimulate menstruation, to encourage conception, or to alleviate various female complaints. This vast body of shared knowledge meant that most women had a functional understanding of their reproductive systems, even if they did not possess a modern biological vocabulary for it. Furthermore, some significant medical texts specifically addressed female health, and while many were written by men, they often drew upon and synthesized this existing body of knowledge. The most famous example is the collection of texts known as the Trotula, a compilation of writings from the school of Salerno in southern Italy, often attributed to a mysterious female author named Trota or Trotula. These texts, incredibly popular and widely copied across Europe for centuries, contained detailed information on gynecology, obstetrics, and cosmetics specifically for women. They described symptoms of various female conditions, offered remedies, discussed birth control methods, and provided advice on childbirth. The existence and widespread popularity of such texts indicate a society that acknowledged and sought to understand female bodies, and that women were active beneficiaries of this knowledge, not ignorant of it. These texts were translated into vernacular languages, making their content accessible to a broader audience, including literate women or those who could have them read aloud. The medieval understanding of conception also reveals a complex, if different, view of reproduction. It was often believed that both male and female seeds were necessary for conception, and that female pleasure during intercourse was crucial for the woman to release her seed. This belief gave women a significant active role in the act of creation, rather than being merely passive receptacles. While this may seem unscientific by modern standards, it implies a level of bodily awareness and an understanding of the relationship between sexual experience and fertility that contradicts the notion of ignorance. Women understood the timing of intercourse in relation to their cycles, even if their understanding of ovulation was not fully developed. They knew when they were most likely to conceive based on their observations of their own bodies. Attempts at contraception and abortion, though often risky and ineffective, also demonstrate a desire by women to control their reproductive lives and a practical knowledge of methods believed to achieve these aims. Medieval sources, including medical texts and legal records, mention various herbal concoctions and practices intended to prevent pregnancy or induce miscarriage. While not always successful, the very existence of these practices points to a belief in bodily autonomy and a shared knowledge among women about how to influence their reproductive outcomes. This knowledge was often passed down through a secretive, informal network, highlighting its importance to women who sought to manage their fertility in a world with limited options. Beyond the specific mechanics of reproduction, women also had a practical knowledge of their general health. They understood symptoms of common illnesses, knew which herbs eased pain or reduced fever, and understood the importance of diet and hygiene in maintaining health. This knowledge was fundamental to managing their households and caring for their families, meaning women were constantly engaged with practical health care. They would observe changes in their own bodies and those of their family members, understanding what felt right and what signaled imbalance or illness. This ongoing, intimate relationship with their physical selves belies the idea of complete ignorance. Religious and spiritual beliefs also intertwined with understanding the body. Prayers, charms, and rituals were often employed alongside practical remedies for fertility, safe childbirth, or healing. Women understood the spiritual dimension of their bodies and sought divine intervention for health challenges. This was not a sign of ignorance about the physical body, but rather a holistic view that encompassed both the material and the spiritual. A woman might pray to a saint for a safe delivery while also preparing a birthing stool and herbal teas. Her knowledge was multifaceted, drawing from various realms of understanding. The idea that medieval women were ignorant about their bodies discounts the rich oral traditions, the widespread medical texts aimed at women, and the lived experiences of women who actively managed their health and reproduction. They observed, learned, shared, and applied knowledge that, while different from our own, was deeply practical and relevant to their lives. They were not passive receptacles of ignorance, but active participants in understanding and navigating the complexities of their physical selves within the framework of their world. Their knowledge was passed down, adapted, and utilized, showing a clear engagement with the realities of their bodies and reproductive functions. Number 3, childbirth was always deadly for women and babies. A common and often dramatic portrayal of medieval life suggests that childbirth was an almost guaranteed death sentence for women and their newborns. Stories are filled with high mortality rates, women dying in agony, and infants rarely surviving their first days. This idea, while certainly touching upon the very real dangers of childbirth in any era before modern medicine, oversimplifies a complex reality and exaggerates the universal outcome. While childbirth was undoubtedly one of the riskiest events in a medieval woman's life, it was not always deadly, and many women survived multiple pregnancies, giving birth to thriving children. The narrative of universal doom ignores the widespread survival and the sophisticated, if often informal, practices developed to assist women through labor and delivery. It is important to acknowledge the inherent dangers. Infections, hemorrhages, obstructed labor, and the lack of truly effective pain relief or surgical intervention meant that complications could quickly become fatal. Without antibiotics, even a minor tear during birth could lead to a deadly infection. Without transfusions, severe blood loss was often irreversible. And in cases where a baby was positioned incorrectly, intervention options were extremely limited. Yet, despite these formidable challenges, life went on and populations continued to grow. High fertility rates throughout the medieval period, where women often had many pregnancies, strongly suggest that a significant number of women not only survived, but often survived multiple births. If every birth was fatal, medieval societies would have collapsed from lack of reproduction. As midwives played an absolutely crucial role in mitigating the dangers of childbirth. These skilled women, often older and highly experienced, were the primary attendants at births across all social classes. They possessed a vast reservoir of practical knowledge passed down through apprenticeship and generations of female wisdom. A midwife would typically recognize signs of a difficult labor, suggest positional changes for the mother to ease the birth, and offer herbal remedies to encourage contractions or reduce pain. They knew how to handle basic complications, such as a prolonged labor, and understood the importance of cleanliness, even if the concept of germ theory was unknown. They brought a calm, experienced presence to the birthing room, which was often a stressful and emotionally charged environment. Their expertise was vital to the survival of both mother and child. The birthing environment itself was often designed to support the laboring woman. Birthing stools, for example, were common tools that allowed women to give birth in an upright or squatting position. This position is known to be more effective and often less painful than lying flat, using gravity to assist the descent of the baby. The use of such specialized equipment, rather than a lack of foresight, indicates a pragmatic approach to facilitating a safe delivery. The birthing room was almost exclusively a female space attended by the midwife, female relatives, and close neighbors. This communal support network provided comfort, encouragement, and practical assistance, demonstrating a concerted effort to aid the woman through her ordeal. After the birth, the lying-in period was a crucial time for the mother's recovery. Women were often confined to their beds for several weeks, receiving special care, nourishing foods, and protection from drafts and cold. This period of rest and recovery was understood as essential for the mother's healing and for the establishment of breastfeeding. While this practice was not always sufficient to prevent all complications, it certainly helped reduce the risk of infection and exhaustion, contributing to the mother's survival and recovery. The community understood the vulnerability of the new mother and acted to protect her during this delicate time. While statistics are difficult to come by for the entire medieval period, localized studies and records indicate that maternal mortality rates, while higher than today, were not universally catastrophic. For instance, some estimates suggest that perhaps 1 to 2% of births resulted in the mother's death. While this figure is tragically high by modern standards, it means that 98 to 99% of mothers survived, a far cry from an always deadly scenario. Infant mortality, particularly in the first year of life, was indeed very high due to disease, malnutrition, and poor hygiene, but this is distinct from death during the birth process itself. Many babies who survive birth succumb to illnesses like dysentery or measles in their early years. Religious beliefs and rituals also played a significant role, not as a replacement for practical care, but as a complementary layer of support and hope. Women would pray to saints, wear special amulets, or invoke divine protection during labor. This spiritual dimension offered comfort and a sense of control in an unpredictable world, helping to manage the fear and anxiety associated with childbirth. It was a coping mechanism, not necessarily an indication of medical ignorance, but an acknowledgement of the limits of human intervention in the face of natural processes. Consider royal births, which were often meticulously documented. While some royal women did die in childbirth, many others, like Eleanor of Aquitaine, who had 10 children, or Eleanor of Castile, who had 13, survived numerous pregnancies. Their survival, though potentially aided by better nutrition and care, demonstrates that even high-status women, facing the same fundamental biological process, were not guaranteed to die with every birth. Their experiences, while not typical of all women, show that survival through multiple births was entirely possible and not an exceptional rarity. Ultimately, the portrayal of medieval childbirth as universally deadly is a simplification that overlooks the practical skills of midwives, the communal support systems, and the inherent resilience of women. While the risks were substantial and deeply understood by those who lived through them, the majority of women survived their pregnancies and deliveries, contributing to the ongoing life of medieval societies. Their experiences were a testament to the adaptive strategies developed to navigate a hazardous but essential part of human existence, proving that life continued and families grew, defying the myth of constant fatality. Number 4. Medieval healthcare was universally primitive and ineffective, especially for women. The belief that medieval healthcare was nothing more than a series of barbaric, ineffective, and often dangerous practices, particularly for women, is a widely circulated myth. This idea often conjures images of crude surgical tools, reliance on superstitions, and a complete lack of understanding of the human body. This simplified view fails to recognize the complexity, the regional variations, and the surprising effectiveness of many medieval medical practices. It also overlooks the evolving nature of medical knowledge and the presence of sophisticated theoretical frameworks that underpin much of medieval healing, including care for women. Medieval medicine, like all aspects of medieval society, was not static. It built upon the foundations of ancient Greek and Roman medicine, particularly the humoral theory, and was significantly influenced by the advanced medical traditions of the Islamic world. European scholars translated and absorbed texts from Arab physicians like Avicenna and Rhazes, who had preserved and expanded upon classical knowledge. This intellectual cross-pollination led to a rich, if sometimes disparate, body of medical understanding. Physicians, apothecaries, and surgeons, often male but sometimes female, operated within this framework, attempting to diagnose and treat illnesses by restoring the balance of humors in the body. This approach, while different from modern germ theory, was a systematic and logical way of understanding disease for its time. Herbal medicine was a cornerstone of medieval healthcare, and it was far from primitive. Thousands of plants were known for their medicinal properties, and their uses were meticulously documented in herbals and medical receipt books. Many of these plants, like poppy for pain relief containing opium, willow bark for fever containing salicylic acid, a precursor to aspirin, or digitalis for heart conditions, indeed possess active pharmacological compounds recognized by modern science. And women, particularly, were adept at cultivating and preparing these herbal remedies within their households. They knew how to make poultices, infusions, decoctions, and salves. This knowledge was practical and often effective in alleviating symptoms, managing chronic conditions, and promoting recovery. It was a sophisticated system of pharmacology based on centuries of observation and experimentation. Surgery, though certainly dangerous without anesthesia and sterile techniques, was practiced and was not always crude. Medieval surgeons, known as barber surgeons due to their dual roles, performed operations such as setting broken bones, amputating limbs, removing cataracts, and treating wounds. Archaeological finds have uncovered a variety of surgical instruments, some surprisingly delicate and well-designed, indicating a level of craftsmanship and intention. For women, specific surgical procedures were rarer, but not unheard of. For instance, C-sections were performed, though almost always on dead or dying mothers in an attempt to save the infant, reflecting a pragmatic, if tragic, application of surgical knowledge. Wounds from accidents or violence, affecting women as well as men, were routinely treated, often with surprising success given the limitations of the era. Hygiene, while not understood in the modern germ theory sense, was also considered important. Public bathhouses were common in many medieval towns, and while they varied in cleanliness, the concept of bathing and personal cleanliness was present. Monasteries and hospitals often had sophisticated water systems and an emphasis on fresh air and proper waste disposal. While outbreaks of plague and other diseases certainly occurred, this was due to a lack of understanding of microorganisms, not a complete disregard for cleanliness. The women were often responsible for household cleanliness, which included basic sanitation practices that contributed to health. For women-specific health issues, medieval texts and practices show a nuanced approach. Conditions related to menstruation, pregnancy, and childbirth were extensively discussed. The Trotula texts, for example, contain detailed advice on managing menstrual cramps, dealing with infertility, and preparing for childbirth. These texts offered a range of treatments, from dietary advice and herbal remedies to specific physical manipulations during labor. While some treatments might seem strange today, they represented the best available knowledge at the time and were rooted in observation and a desire to alleviate suffering. The physicians and healers of the time were actively trying to understand and treat female-specific ailments, not simply ignoring them. Even the concept of hysteria, from the Greek hystera, meaning womb, often misunderstood as solely a diagnosis for female emotional instability, was also understood within the humoral framework. It was often linked to imbalances in the womb or its wandering through the body seeking moisture. While this understanding is not accurate, the treatments suggested, such as aromatic fumigations or placing strong smelling substances near the nose or genitals, were attempts to restore balance, not simply dismiss women's suffering. It was a medical explanation, albeit a flawed one, for symptoms that medieval practitioners struggled to explain. Consider the role of diet and regimen. Medieval medicine placed a strong emphasis on maintaining health through proper diet, exercise, sleep, and regulating emotions. This regimen applied to women as much as men and was seen as a preventative measure and a therapeutic tool. Specific diets were recommended for different humors, conditions, or life stages, including pregnancy and lactation. This holistic approach recognized the interplay between lifestyle and health, demonstrating a sophisticated awareness beyond just treating symptoms. In conclusion, to label medieval healthcare as universally primitive and ineffective for women or anyone else is to oversimplify a period of evolving medical thought and practical application. While certainly lacking modern scientific understanding and technology, medieval practitioners and lay healers alike utilized a complex system of knowledge, including effective herbal remedies, practical surgical skills, and a holistic approach to health. Many practices were surprisingly effective in alleviating symptoms and promoting healing within the context of their time, directly challenging the notion of universal ineffectiveness. Number 5. Medieval women were always passive recipients of care, never practitioners. The persistent myth that medieval women were merely passive patients, always on the receiving end of medical treatments and never active participants or practitioners in the healing arts, paints an incomplete and misleading picture of their historical roles. This view often limits their interaction with healthcare to being cared for by male physicians, denying them any agency or expertise in the field. However, historical records, archaeological evidence, and surviving texts reveal a vibrant and multifaceted reality where women were deeply involved in healthcare, not only as patients but as healers, caregivers, and knowledgeable experts in their own right. They were foundational to the daily health of their communities, actively engaged in a vast informal and sometimes formal medical network. One of the most undeniable and widespread roles for women in medieval healthcare was that of the midwife. Midwives were indispensable figures in every community, from the humblest village to the grandest royal court. They were almost exclusively women, and their expertise was crucial for safe childbirth. And midwives were not just present during labor. They often provided prenatal advice, assisted throughout the delivery, and offered postnatal care for both mother and infant. Their knowledge was passed down through generations, often through apprenticeship, and involved practical skills like managing labor, recognizing complications, and performing basic interventions. Women in labor actively sought out and relied on these skilled practitioners, making midwives powerful and respected figures. Their presence was a testament to women's active role as primary caregivers for life's most vulnerable moments. Beyond childbirth, women were the primary practitioners of household medicine. In every home, regardless of social status, women were responsible for the health and well-being of their families. This meant they were constantly engaged in diagnosing common ailments, preparing remedies, and nursing the sick. The household garden often served as a miniature apothecary filled with herbs like chamomile for calming, mint for digestion, or comfrey for wounds. Women learned to cultivate these plants, harvest them, and transform them into salves, poultices, teas, and tinctures. They understood which plants could reduce fever, soothe pain, or aid digestion. This knowledge was empirical, based on generations of observation and tradition, and was actively applied daily. These women were not formally trained physicians, but they were competent and effective practitioners of a vital form of primary health care. Some women also specialized in specific healing arts and operated beyond their own households. There were female herbalists who collected and sold medicinal plants and remedies in markets, offering their knowledge to the wider community. There were women known as bone setters who, through practical experience, could mend fractures and dislocation. While not as formally recognized as university-trained physicians, these female practitioners often had strong reputations and were sought out by people who trusted their practical skills and accessibility. In guild records from various towns in medieval Europe sometimes mention women engaging in medical trades, such as apothecary work or even barber surgery, though these were less common and often restricted by gender norms or formal guild structures. Women also played a significant role in institutional healthcare, particularly within religious orders. Nuns, for example, were often actively involved in running infirmaries within convents and monastic hospitals. They cared for sick nuns, but also for the poor, the elderly, and the sick from the surrounding community. These nuns provided nursing care, administered herbal remedies, and offered spiritual comfort. Some, like Hildegard of Bingen in the 12th century, were renowned for their extensive medical knowledge and wrote treatises on natural history and medicine that were widely studied. Her work, such as Physica, detailed the medicinal properties of plants, animals, and minerals, showing a deep academic engagement with healing by a woman. These women were not just passive caregivers, they were active, knowledgeable practitioners within a structured medical environment. Furthermore, women were not just users of medical knowledge, they were also contributors to it. The aforementioned Trotula texts, a collection of treatises on women's health, were widely copied and studied across Europe for centuries. While the authorship is debated, the tradition holds that one of the primary authors was a female practitioner named Trotula of Salerno. Regardless of precise authorship, the texts demonstrate a detailed understanding of female anatomy, gynecology, and obstetrics, compiled and utilized within a medical context. The very existence and widespread dissemination of texts focused on women's health indicate that there was an active body of knowledge, much of it likely stemming from the practical experience of female healers that was deemed valuable and worth preserving. Even in situations where male physicians were involved, women were not always silent patients. Wealthy women, for example, would often articulate their symptoms, ask questions, and make decisions about their treatment, especially if they were the heads of their households or had significant influence. Their receipt books, personal diaries, and household accounts sometimes reveal their active engagement with medical practitioners and their personal decisions about remedies. Women of all social classes would discuss their health with other women, sharing experiences and advice, thereby actively participating in their own healthcare decisions and that of their families. The idea of women as passive recipients of care ignores the vast network of female healing and knowledge that permeated medieval society. From the indispensable midwife to the skilled herbalist in every household, from the compassionate nun in the infirmary to the occasional female surgeon or apothecary, women were central to the provision and transmission of healthcare. They were not merely patients, they were active, knowledgeable, and often leading figures in the daily struggle against illness and the maintenance of health for themselves and their communities. Their contributions to medieval healthcare were profound and deeply embedded in the fabric of everyday life, challenging any notion of their passive role.